Welcome to the deep dive. So I want you to imagine going into a clinic for like a routine aesthetic procedure. You get a filler injected, you heal up perfectly, you feel great.
Right, a total success story.
Exactly. The results are exactly what you wanted. But then, almost a year later, you spend a Saturday afternoon planting tomatoes in your backyard.
As one does.
Yeah. And you scrape your knuckles a little bit on the dirt. I mean, nothing major, just a tiny scrape. But then, 3 days later, that old filler site suddenly swells up into this painful, hardened mass.
Which sounds completely unrelated.
Right. But somehow, a minor scrape in the garden has instructed your immune system to launch a targeted attack on an implant you had, frankly, forgotten was even there.
I mean, it sounds like medical fiction, but the stack of clinical studies and dermatological case series we're analyzing today shows this is a very real, incredibly complex phenomenon.
Yeah, we're venturing into this highly specific intersection of aesthetic medicine, immunology, and intimate health.
It's a fascinating area.
It really is. So our mission for this deep dive is to unpack exactly how and why our immune systems can just unexpectedly turn against intimate hyaluronic acid fillers months or even years after a completely uneventful procedure.
Right, because the timeline is what makes it so bizarre.
Exactly. We're going to break down the mechanics of delayed type hypersensitivity, look at the wild everyday things that trigger it, and most importantly, explore the step-by-step clinical algorithms doctors use to play detective here.
Because diagnosing and managing these reactions in such highly sensitive areas requires a very specific protocol. We're essentially dissecting a perfect storm of anatomy, aesthetics, and immune memory.
Yeah, and we should note that the demand for both functional and aesthetic intimate rejuvenation is just skyrocketing right now.
Which means we are getting a lot more long-term data on how these materials actually interact with our biology.
Right, and the sources show this trend isn't just driven by cosmetic desire, There is a massive functional component to this.
Oh, absolutely.
For women, the clinical literature focuses heavily on labia majora volume restoration. So patients are seeking to address tissue atrophy and laxity, but also serious functional issues like decreased lubrication, mucosal fissures, and actual discomfort during intercourse.
Which are very real, very common realities associated with aging or hormonal changes, childbirth, significant weight loss, all of that.
Yeah, exactly. And similarly, the data shows a really significant rise in men seeking penile enhancement procedures.
And the material driving nearly all of these intimate procedures is cross-linked hyaluronic acid, or HA.
Right, the golden child of fillers.
It really is. The case series we're reviewing note that HA currently represents like 78% of all injectable dermal fillers on the market. It is the absolute gold standard for tissue volumization.
So I want to understand why HA has that kind of monopoly. Like if a doctor is working in such a complex, vascular, sensitive area, what makes this specific sugar gel the tool of choice?
Well, it really comes down to how HA fundamentally interacts with human tissue. So hyaluronic acid is hydrophilic, meaning it has an incredible ability to bind to water molecules.
Like a sponge.
Exactly, like a highly efficient, biocompatible sponge. When it's injected, it immediately draws in hydration, adding instant volume and structural support.
Wow.
But the benefits actually go beyond that initial plugging effect. As the HA sits in the tissue, it physically stretches the local fibroblasts.
And those are the cells that build the structural framework of your tissues, right?
Exactly. So this mechanical stretching actually stimulates the body to produce new de novo collagen.
Okay, so the filler acts like a scaffolding that basically tricks your body into rebuilding its own natural structural support.
That's the mechanical benefit, yeah.
Right.
But the biological benefit is that hyaluronic acid is already a major, naturally occurring component of the human extracellular matrix.
Right, it's already in us.
Abundant in your skin, your joints, your connective tissues. And because of that natural prevalence, the medical community typically considers HA to be non-immunogenic.
Meaning the immune system just ignores it.
Basically, yeah. When an HA filler is introduced, the body's immune surveillance looks at the molecular structure and essentially registers it as familiar, safe material.
And the techniques doctors use to place this familiar material are getting really advanced too. Like one of the novel labia majora procedures in our sources describes using an 18-gauge, 50-millimeter long microcannula.
Which is quite long for that area.
Right. But under local anesthesia, they create these subcutaneous tunnels and use a retroinjection technique. So they deposit the HA gel slowly as they pull the cannula backward through the tissue.
Laying down a very precise amount, usually about 1 to 2 milliliters per side.
Yeah, and the literature notes they use similar cannula-based techniques for penile enhancements, which results in minimal downtime and highly rated functional outcomes for the patients.
The clinical outcomes are overwhelmingly positive, I mean, across the board. But yes, the sheer volume of these procedures being performed globally is revealing a fascinating immunological blind spot.
Right, and this is where I want to push back a little. Because if HA is a naturally occurring sugar that's already abundant in our bodies, the immune system should just give it a free pass, right?
You would think so, yes.
So why would the literature on penile HA injections specifically document a 2.2% rate of subcutaneous nodules? I mean, if our bodies inherently know this material, why is the immune system occasionally forming these hardened lumps around it?
Well, the catch is that the hyaluronic acid in a syringe is not identical to the hyaluronic acid your body naturally produces.
Oh, interesting.
Yeah, if a doctor injected pure, unmodified HA into your tissues, your body's natural enzymes would just metabolize and dissolve it in about 3 days.
Which defeats the purpose of a filler.
Right, exactly. So to make a dermal filler that lasts, say, 12 to 18 months, pharmaceutical companies have to modify it. They use chemical agents to cross-link the HA molecules.
Cross-link meaning what exactly?
It creates these complex bridges between the sugar chains, and this chemical modification makes the gel much denser and highly resistant to enzymatic breakdown.
Okay. So the cross-linking fundamentally changes the molecular signature of the sugar. So it might look familiar to the immune system at first glance, but it's technically a foreign synthetic structure.
Yes. And that subtle structural difference is the staging ground for complications. While the overall complication rate remains exceptionally low, a specific issue arises when the immune system suddenly stops recognizing that modified HA as friendly.
It just flips a switch.
Exactly. It flags the filler as a foreign invader. And this brings us to the core clinical challenge outlined in these studies, delayed type hypersensitivity.
The time bomb effect. So how does a delayed reaction actually work on a cellular level? Because when I think of an allergic reaction, I think of like someone with a peanut allergy eating a peanut and immediately going into anaphylaxis.
Right, but a peanut allergy is a type of hypersensitivity reaction. It's immediate, happening in minutes or hours.
Okay, so that's the fast one.
Yeah, type I reactions are mediated by IgE antibodies, which basically trigger your mast cells to dump massive amounts of histamine into your system. That histamine is what causes the immediate hives, the swelling, the airway constriction.
Got it. But the reactions documented in these intimate filler case studies are completely different from that.
Very different.
The sources show patients go through what the literature calls a quiescent state. You know, they get the filler, everything looks and feels perfect for 6, 8, even 12 months.
Total silence from the immune system.
Yeah. And then, seemingly out of nowhere, they develop these alarming symptoms. The sources specifically list erythema, which is severe redness, and induration.
Which is a sudden hardening of the tissue.
Right. And then solid, non-pitting edema, so really intense swelling. In intimate areas, this can literally mean painful, firm nodules forming right where the filler was placed.
It's severe. And that's because delayed type hypersensitivity, or DTH, is a type 5e reaction. It does not rely on those rapid IgE antibodies or histamine.
Oh, so it's a totally different mechanism.
Entirely. It is T-cell mediated. T-cells are basically the heavy infantry of the immune system, and they take time to mobilize.
So they aren't rushing in like histamine.
No, when they encounter a foreign substance, they slowly sensitize to it, building the cellular memory over time. They can literally observe that cross-linked HA filler for a year without doing a thing. The filler just sits there, dormant.
Which means something specific has to provoke those sensitized T cells into actually attacking. The filler is just the kindling. Like, what acts as the match?
Well, the sources break the initial risk factors down into 2 categories, mechanical and manufacturing.
Okay, let's start with mechanical.
Mechanically, the cannula techniques you mentioned earlier can actually play a role. Cannulas are blunt instruments. That makes them a lot safer around blood vessels, but they lack the sheer precision of a sharp needle.
Which means you could accidentally put the filler in the wrong spot.
Right. Large volumes of filler can sometimes be inadvertently deposited in the wrong tissue plane, which creates localized mechanical stress.
And from a manufacturing standpoint.
Well, creating that complex cross-linked gel isn't a perfectly clean process. Industrial processes can leave behind trace microscopic impurities or bacterial endotoxins.
Right, so there's this microscopic debris in there.
And furthermore, as that dense HA gel very slowly breaks down over the months, it releases low molecular weight fragments into the surrounding tissue.
Like little pieces breaking off.
Yeah, and the leading theory in the dermatological literature is that these specific degradation fragments might act as independent inflammatory triggers.
Okay, so a patient has this pocket of modified filler sitting in a sensitive area. It's slowly breaking down. Maybe there are some trace endotoxins present, and the T cells are quietly watching it. But why does it suddenly swell up into a painful nodule on like a random Tuesday in November?
Because the immune system requires a systemic catalyst to push it over the edge into an active attack.
And this is the wildest part of the sources to me. The catalysts documented in these clinical studies are just bizarre. Like one of the most frequently cited triggers for these intimate flare-ups is the flu.
Yes, a simple flu.
Cases show patients experiencing intense DTH reactions flaring up 3 to 5 days after coming down with a standard influenza-like illness, complete with a fever, sore throat, cough.
And the data surrounding COVID-19 provides even more clarity on this mechanism.
Oh yeah, tell me about that.
Dermatologists noted a significant spike in patients experiencing local hypersensitivity reactions at filler sites shortly after being infected with the SARS-CoV-2 virus. And interestingly, also after receiving mRNA COVID-19 vaccines.
Wait, I am trying to map the logic here. Because if I catch a respiratory virus, my immune system mounts a defense in my lungs and my bloodstream.
Right.
How does that systemic defense mechanism end up attacking dermal filler localized in, like labial or penile tissue?
The scientific term for this phenomenon is cross-reactivity. When your body detects a virus like SARS-CoV-2, it produces a massive systemic inflammatory response.
Like ringing the alarm bell.
Exactly. Millions of immune cells are deployed into the bloodstream on high alert, just actively hunting for the viral antigen. And as these hypervigilant T cells circulate through your body, they eventually pass by that localized pocket of cross-linked HA filler.
And because of the synthetic chemical bonds, or maybe those breakdown fragments, the immune system gets confused.
Very confused. It mistakenly registers structural similarities between the HA filler and the specific proteins of the virus.
So it's essentially a flawed facial recognition system.
That's a great way to put it.
The immune system acts like a security guard looking for a specific suspect, right? The virus. It scans the body, spots the HA filler sitting quietly in the tissue, and says, wait, your molecular signature looks vaguely similar to the spike protein on this wanted poster.
Yes.
It misidentifies the filler and redirects a swarm of T cells to attack the implant.
The cross-reactivity is driven by this state of generalized immune hypervigilance. The body is primed to fight a war, and it accidentally opens a second front at the site of the filler.
Which perfectly explains that gardening case study from the beginning.
Exactly.
That patient didn't catch a virus, they just played in the dirt without gloves. They got minor abrasions on their hands, which caused transient bacteremia.
Meaning a very small amount of soil bacteria temporarily entered their bloodstream.
Right. And that microscopic, momentary bacterial presence was enough to put the systemic immune surveillance on high alert,
Yep.
leading the T cells to aggressively attack an intimate filler they had literally ignored for months.
It really illustrates the sheer sensitivity of our immune surveillance network. I mean, any systemic event that spikes inflammation can theoretically turn an inert implant into an active target.
Honestly, if you're the patient experiencing this, it has to be terrifying. You suddenly develop a painful, firm nodule in a highly vascular, intimately sensitive area.
It causes a lot of anxiety, absolutely.
So how do doctors actually figure out what is going on? Because if I go to the doctor with swelling, they might just assume it's normal localized inflammation or maybe a standard cyst.
Right. And diagnosing DTH requires the physician to really play detective, precisely because normal procedure-related swelling usually resolves in just a matter of days.
But this happens months later.
Exactly. So when a patient presents with sudden induration months after the injection, the physician has to rely on a very specific diagnostic toolkit to see what's happening beneath the surface.
And the sources explicitly highlight ultrasound imaging as the most valuable tool for this.
Sure.
Because, you can't just rely on touch when dealing with complex, intimate anatomy.
Oh, absolutely not. Palpation is essentially guessing. High-frequency ultrasound allows the physician to visualize the exact tissue plane where the filler is resting.
To see if it migrated or was placed wrong.
Right. And more importantly, ultrasound differentiates between fluid and solid masses. So an ultrasound can instantly show the doctor if the swelling is just a harmless, fluid-filled cyst, or if it has formed a solid inflammatory granuloma.
Which would confirm that the immune system has actively walled off and is attacking the filler material. And in the cases where the ultrasound doesn't provide a definitive answer, the clinical teams move to biopsies, right? They perform a fine needle aspiration of the hardened nodule.
And the pathology reports from these cases are fascinating to read.
They really are. They describe finding a, quote, reticular dermal deposit of amorphous material.
Which is just the pathologist physically identifying the cross-linked hyaluronic acid gel under the microscope.
Right. But the crucial part of the pathology report is what surrounds that gel. The source is, quote, the presence of a lymphoeosinophilic infiltrate.
Yes, quite a mouthful.
Right. But translated from pathology terms, that basically means the HA gel is completely swarmed by a dense army of white blood cells.
It is physical, microscopic proof. It confirms that the body has mounted a targeted cellular attack specifically on the filler site.
So once the ultrasound of the biopsy confirms that the physician is looking at a type 5 delayed hypersensitivity reaction, what's next? They have to initiate a highly specialized management protocol, right?
Yes. This is where the clinical algorithm becomes incredibly important, because if a doctor just follows the standard instinct for treating an allergic reaction, it will fail completely.
Yeah, if I wake up with sudden swelling and redness, my immediate reaction is to take an over-the-counter antihistamine, like Benadryl.
But based on the mechanics of a type 5e reaction, that would be completely useless.
It would just do nothing.
It would have zero clinical effect. Remember, we established earlier that DTH is a T-cell mediated response.
Right, no histamine involved.
Exactly. Over-the-counter allergy medications are designed to block histamine release, which is the mechanism of a type IgE reaction. Because a type 5 reaction does not utilize histamine, antihistamine simply cannot stop the swelling or the induration.
Wow. Okay, so you have to bypass the histamine system entirely. So what is the first step in this actual clinical algorithm?
Well, step 1 of the consensus treatment algorithm is highly counterintuitive. Doctors do not start by suppressing the immune system. No. They start with a 3 to 6 week course of dual antibiotics, specifically pairing a fluoroquinolone with either a tetracycline or a macrolide.
Okay, I want to make sure I understand the logic of that. If the pathology report proves this is an immune reaction against a sterile sugar gel, why are doctors prescribing heavy, broad-spectrum antibiotics for over a month?
Because this strategy targets those hidden subclinical triggers we discussed earlier, the medical community operates on the assumption that many of these late-onset DTH reactions are actually being driven by low-grade bacterial biofilms.
Oh, the impurities.
Right. Biofilms that have formed a microscopic shield around the filler material. These biofilms might not cause a full-blown infection, but they constantly irritate the immune system.
Keeping the T cells on high alert.
Exactly. So by administering a long-term dual antibiotic course, the doctor is systematically eradicating any lingering bacterial catalysts that might be acting as the match for the inflammation.
Okay, that makes sense. You clear the invisible infection first, removing any reason for the immune system to be agitated. Right. And then the algorithm dictates a watchful waiting period. The doctor basically monitors the patient for 48 hours to 2 weeks to see if the antibiotics calm the swelling.
Yes.
What happens if the antibiotics fail? Like, what if the immune system just will not stop attacking the HA?
Well, if the induration persists, the physician moves to step 2 of the algorithm, which involves the use of intralesional hyaluronidase.
This is such an incredible chemical tool, like the ultimate CTRL plus Z or undo button in aesthetic medicine.
It really is.
So hyaluronidase is an enzyme that naturally breaks down hyaluronic acid. And when a doctor encounters a severe DTH reaction, they can literally inject this enzyme directly into the inflamed nodule.
And the enzyme acts like a pair of molecular scissors.
Just cutting it up.
Yeah, it physically cleaves the synthetic cross-linked bonds of the HA filler, turning that dense gel back into a liquid that the body can just quickly flush away.
The clinical logic is elegantly simple, right? If the immune system is relentlessly attacking an antigen, you just dissolve and remove the antigen.
Exactly. One of the case studies in our sources noted a patient requiring 150 units of hyaluronidase injected directly into the site to completely melt away the offending material.
Wow, 150 units.
Yeah, and once the filler is gone, the T cells have nothing left to attack and the reaction stops.
But the sources also outline a step 3. For cases that are, like, highly disfiguring or completely recalcitrant,
Right, the tough cases.
meaning the tissue is so inflamed that the hyaluronidase just cannot effectively reach all the filler, or maybe the immune system is just spiraling totally out of control.
In those severe scenarios, the clinical team deploys systemic steroids.
Okay, bringing out the big guns.
Yes. They will prescribe an oral regimen, like a 40 milligram prednisone taper, or they'll inject corticosteroids directly into the lesion.
So how does that differ from the other steps?
Well, unlike the antibiotics, which clear bacteria, or the hyaluronidase, which remove the fillers, steroids are a blunt instrument. They're designed to manually force the immune system to stand down.
Just shut it all off.
They suppress the T-cell response entirely to halt the collateral tissue damage and give the anatomy time to actually heal.
Understanding this algorithm, the ultrasound diagnosis, the dual antibiotics, the enzymatic dissolution, and the systemic steroids, I think it's profoundly important for anyone considering these procedures.
It really provides a lot of clarity.
Yeah, if you or someone you know is exploring HA fillers, especially for highly sensitive, intimate area rejuvenation, knowing that this diagnostic and treatment safety net exists is incredibly empowering.
You're not just at the mercy of a random immune reaction.
Right. Medical science has mapped exactly how to read the ultrasound, how to clear the biofilms, and how to chemically dissolve the problem if your immune system makes a mistake.
It transforms what could be a terrifying medical mystery into a very manageable clinical protocol. I mean, hyaluronic acid remains a phenomenal, naturally derived tool that is genuinely revolutionizing both aesthetic and functional tissue restoration.
But our biology is complex.
Very complex, and immune memory is incredibly long.
Yeah, we have definitely learned today that a perfectly biocompatible, naturally occurring sugar gel can sit dormant in your tissue for months, only to be suddenly attacked by your own T cells because, like, a passing flu virus or a scraped knuckle triggered a microscopic case of mistaken identity.
Which really leaves us with a critical concept to consider regarding the future of medical science.
What's that?
Well, we are rapidly moving into an era of advanced long-term medical implants, personalized biohacking, and even synthetic organ tissues.
Right, we're putting more and more things inside our bodies.
Exactly. So if our highly evolved immune systems can suddenly turn against a simple, naturally occurring sugar gel just because we caught a common cold, what does this cross-reactivity mean for the future of human integration?
Oh, wow.
Yeah, as we engineer more complex materials to exist inside our bodies permanently, will managing our own immune system's misidentifications become the single most difficult hurdle in the future of regenerative medicine?
That is a staggering puzzle for the future of immunology. I mean, the diagnostic landscape might be complex, but understanding how our bodies defend us, even when they make mistakes, is absolutely fascinating.
It really is.
Well, thank you for joining us on this deep dive. Keep questioning the science behind the medicine you encounter every day, and we will see you next time.